in the total number of pumps.
But how long have you been doing this? Like how many? Yeah, yeah, out of all the pumps you've placed, I mean, just one. That's pretty incredible.
World of Pain MD podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The aforementioned does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information in this website. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Hello and welcome to World of Pain MD podcast, where we discuss all things pain with the experts. I'm Dr. Derick Davis, a physician specializing in pain management. In this episode, we speak about intrathecal pump therapy with Dr. Arti Ori. Firstly, Dr. Ori has an awesome name. Secondly, she's dual board certified in both pain management and anesthesiology with experience in advanced interventional therapies like neuromodulation and targeted drug delivery. She's from South Africa, where she attended medical school at the University of KwaZulu-Natal and has spent time in the UK where she trained in emergency medicine. She did a surgical year at Brigham Women's Hospital, where she also did her anesthesiology training. She is no doubt well qualified to be an expert in intrathecal pump therapy and management. In this episode, we'll dive into how the therapy works, its indications, various types of medications that can be delivered to these pumps, providing both immediate relief and long-term management for multiple conditions. Dr. Ori will discuss her experiences with this procedure, what makes it so impactful, and how it fits into a broader landscape of pain management. As always, thank you so much for watching or listening. I hope you enjoy this episode and learn something. Okay, welcome back to World of Pain MD. Thank you so much, Dr. Ori, for being here. We are today talking about intrathecal pump therapy. So what exactly is intrathecal pump therapy, and how does it differ from systemic medication approaches?
When I explain it to my patients, I explain to them that we often turn to intrathecal pump therapy when oral medications are not effective. The intrathecal medications are 100 to 300 times more potent than oral medications. And we're delivering the medication right to the pain receptors, the opioid receptors or baclofen receptors in the spinal cord. So it tends to be much more effective at a lower dose. And because you're using a lower dose, side effects are much less common.
Right. That's one of the main things I think that we sort of counsel patients on when we first talk to them, and why they get referred to us in the first place is because maybe they're on such high doses of oral medications that we have this alternative way of like getting to more direct therapy, which has really opened my eyes up to different ways of treating, patients. So what sort of conditions do you think benefit from intrathecal pumps the most?
So that's a good question. So there are three main patient populations that benefit from intrathecal opioid therapy or baclofen therapy. One, we look at patients with cancer pain. Cancer pain can often be very difficult to treat with just oral medications. And intrathecal therapy is a very effective way of delivering not just pain relief, but improvement in quality of life for patients at the end of their lives. Another population is a chronic pain population. So patients who failed more conservative therapies like injection therapies. Maybe they've had a spinal cord stimulator in and that hasn't worked for them. You know, with the current opioid crisis, we're more and more hesitant to prescribe oral pain medications. And with prescribing oral pain medications comes the risk of overdose, opioid-induced hyperalgesia, tolerance, dependence, all of those things. So intrathecal opioid therapy is an effective way of delivering pain relief that's often much less risky than prescribing oral pain medications. And then finally, the last group of patients is spasticity patients. Patients who have spasticity refractory to oral muscle relaxants, like baclofen, or who are just not able to tolerate these sedating medications.
And these spasticity patients, is this, do you see primarily like patients that have had spinal cord injuries, or is it patients that have had, maybe congenital issues from when they were born? Or what would you say is the mixture of the patient population you see for spasticity?
Generally, the most common indication would be spasticity from a disease like MS,
Okay.
spinal cord injuries, though, patients with CP from birth. But more and more, we're seeing use of intrathecal baclofen therapies for more unusual conditions like ALS.
Okay. Interesting. And who do you determine to be ideal candidates when it comes to opioid therapy, for instance, or even for spasticity? How do you go about determining who's the ideal candidate for an intrathecal pump?
So that takes very careful attention to selecting the appropriate candidate using an algorithm in your head. So what I think of is a patient who ideally is opioid naive or somebody who can't tolerate oral medications. For me, the most ideal pain pump patient is that 80-year-old with chronic compression fractures who can't tolerate one pill of Vicodin. And that patient has such an improvement in quality of life.
Do you find that patients continue to need increasing doses of opioids as time goes on for their, if it's like an intrathecal pump for pain?
That's a good question. So it brings you back to appropriate patient selection and setting expectations at the very beginning. It's important to let your patient know that you're going to help them manage their pain enough that they can be more functional, but you don't promise 100% pain relief. So with that in mind, patient has different expectations to somebody who would expect to be completely pain-free and then would require or ask for increasing doses of opioids. That having been said, tolerance does develop over time, but if titrated carefully with a catheter tip in the correct position, treating the pain very thoughtfully, you can avoid unjudicious escalations.
Yeah.
Dose.
What, prior to putting in a pump, we do what's kind of the trial phase of pumps. What does that look like before we move on to placing in our permanent pump?
So the trial gives us an idea as to whether this medication or this route of delivery of medication would be appropriate for the patient, would be effective in relieving their symptoms, and also not cause side effects. We usually give them a single shot dose of opioid intrathecally in the space around the spinal cord, and then we monitor their response to that, make sure they don't have side effects. And then in clinic, we assess their functional status. Okay, are you able to walk easier? Does gait change? Or in the case of spasticity, do we see a reduction in tone or an improvement in spasms in the period of time they're in the clinic?
How long do those trial phases usually last in clinic? Are they there for 4 hours? Are they there for 2 hours, half an hour? What do you usually see?
So usually for a baclofen trial, we want them there for the peak onset of the medication, which is around that 3 to 4 hour mark.
Okay.
Most of the times I have my answer by 3 hours and I let a patient go early, but I also let them know this medication is likely going to last 8 hours, maybe longer, so you will feel loose for a while. In terms of, I use fentanyl for my opioid trials. In terms of that, I usually keep them in clinic for an hour. That's enough time for the onset of fentanyl, enough to determine the reduction in pain scores and improvement in function. And then fentanyl, of course, will wear off by 4 hours. So we'll have our answer before that.
What about contraindications? So are there reasons why people cannot have intrathecal pump therapy? Are there patient populations that should not get it?
All our patients, except cancer patients who get pumps, undergo a psych evaluation. And that's really important in determining if there are other factors like malingering, but also to determine the patient's ability to manage an implant.
Right.
I always try to make sure patients understand the commitment to having an implant.
Right.
They need to be present at all their refills. They can't skip refills if they're traveling out of the country. Contingency measures need to be made. For example, if it's a baclofen pump, they should have oral baclofen with them. And that takes a certain element of responsibility.
Yeah.
So in the patient that may not be able to care for themselves effectively and don't have a good support system, it would be very difficult for them to manage a pump.
And why is it that they need to have consistent follow-up? What happens if the pump runs out of medication?
If the pump runs out of medication, it doesn't stop working. It's continuously working, but it starts to beep, and then the patient goes into withdrawal from that medication. Baclofen withdrawal can be life-threatening.
Yeah.
Right.
Opioid withdrawal will result in symptoms of opioid withdrawal, like sweatiness, nausea, that kind of thing, feeling like you have a flu, but is not life-threatening.
What medications are typically used in pumps? And is there a particular reason why you think those medications are used?
Yeah, so FDA-approved medications or on-label use of medications include morphine, Prialt, ziconotide, and baclofen. But you're right, we do use a combination of medications sometimes. For example, in cancer pain, we found in our practice that a combination of a local anesthetic like bupivacaine, an opioid like hydromorphone, and clonidine as an adjuvant works very well in tackling cancer pain. Cancer pain responds very well to bupivacaine, so we tend to use a triple mix for that. In patients who are receiving a pump for chronic non-malignant pain, we prefer to use monotherapy. The reason being is it's easier to titrate a medication. If the patient has side effects, you can attribute it to that medication solely. And also, rotor malfunction in pumps have been associated with the use of combination medications.
I did not know that. How do you approach these titrations over time and avoid complications like maybe pump malfunction or granuloma formation?
Granulomas form with high doses of opiates as well as high concentrations. And it's important to always be thinking about the possibility of granuloma formation when you see your patient, every time you see your patient. So if they have onset of a new neurological symptom that they didn't have before, it's important to get an MRI so you can screen for a granuloma. Of course, the thing we worry about with granulomas is that they progress to the size where they compress the spinal cord and then cause issues of cord compression.
And while we're just on the topic of complications, so we are entering into the intrathecal space during this procedure, which means that we go into the space that contains the CSF, and subsequently that's known to cause things like post-dural puncture headache. How do you deal with a suspected post-dural puncture headache after placing a pump?
I always counsel a patient beforehand to expect a post-dural puncture headache.
Okay.
And that way they're prepared for it. In the vast majority of cases, if a patient does develop a post-dural puncture headache, it resolves within the first few days with conservative management of fluids and hydration, caffeine, or Furoset medication.
Yeah.
But should it be persistent, and if it looks like there's a seroma forming around the catheter and site, then it's important to get some imaging and determine if there's an ongoing dural leak. If there isn't those indications, you could always consider doing a blood patch. I did have a patient, cancer pump, who had an intractable post-dural puncture headache a few weeks after a pump, got an epidural blood patch and did better. So very, very small and in the total number of pumps.
But how long have you been doing this? Like how many? Yeah, out of all the bumps you've placed, I mean, just one. That's pretty incredible.
I think most of the time patients are just really grateful to have this avenue for the pain relief. And a post-dural puncture headache is just seen as a minor nuisance.
When you go about placing an intrathecal pump, what are some key considerations? Whether it be, are they on an anticoagulant? Do they need antibiotics for long periods of time? What are some things that you kind of check off in your mind before you say, okay, we can go, all green lights?
Sure. Preoperatively, globally, I look at the global picture of the patient. You know, how frail are they? Is this somebody who's more likely to develop an infection? You know, is it a smoker? I always have patients stop smoking for a month before the pump is implanted. Sometimes it's not always easy to elicit that history. However, you can obtain a urine or serum cotinine test just to, make sure they really have been off cigarettes. And then I look at things like risk factors for infection or bleeding, as you mentioned, anticoagulation. I follow the ASRA guidelines for holding anticoagulation for the pump placement. And then in terms of diabetes, I make sure that their diabetes is well controlled. If not, then we put a hold on things until they're able to see their endocrinologist and get things under control. I always tell patients, it's worth waiting a little longer and getting them medically optimized than having to remove a pump.
Is there a certain A1C that you look for that means well controlled to you, or is it like just perioperative glucose control, or what do you look for when it comes to diabetes control?
So I look at the A1C, but recent data has shown what's more important is perioperative glucose control. However, if I see an A1C that's persistently 12, I know right away I'm not gonna schedule this patient. We're gonna get things optimized.
Yeah. Can you talk about catheter tip placement and where you find the best therapeutic effects per what sort of diagnosis or what sort of issue the patient's dealing with?
In the past, we thought that CSF just sort of flowed up and down all around. Medication spread to wherever it needed to go to. But with recent cadaveric studies, we now know that it's very important to deliver the medication very close to those opioid or baclofen receptors in the dorsal horn of the dorsal column of the spinal cord. And that CSF flow is actually lamellar and doesn't flow as vigorously as we thought.
Okay.
Also, given the fact that we're using lower doses now, we really want to make sure that the tip of the catheter is as close to the dermatome of pain as possible.
Yeah.
It's also very important to make sure the catheter is placed dorsally because a ventrally placed catheter shows very poor spread to the posterior epidural space where those receptors are.
During a pump implant, what are some of the technical challenges that have happened, and how do you handle them?
So BMI is probably one of the more common challenges we face.
All right.
And if preemptively I determine somebody may be a difficult placement, then I'll elect to start the case prone, place the catheter prone, tunnel it, and then flip to supine and make the pocket. It's much easier to do these spine procedures in the prone position versus in the lateral position. Other technical challenges I've come across are patients who've had multiple spine surgeries, and sometimes there can be adhesions that affect the flow of CSF, and you don't get CSF where you expect to, or it may be difficult to even enter the intrathecal space. In those situations, it's really important to have a neurosurgeon buddy on standby who can come in and make a laminotomy for you to pass the catheter through that bone mass.
Whether it is post-dural puncture headache, or if it's granuloma formation or pump malfunction, but are there any other major risks or complications you've found with these pumps?
I think managed carefully, risks are mitigated, but there's always a risk of overdose. We're dealing with very, very potent medications, and even small adjustments can cause large clinical repercussions. So, for example, when I program a pump or make an adjustment to a dose, I always make sure there's a second pair of eyes that goes through it with me, and I recite it out loud, the changes I've made, and check it multiple times. It's very easy to miss a decimal point.
It is.
Which can have significant repercussions.
Absolutely. That's why we have kind of many safeguards in clinic when, like you said, when you're changing the dose, we go check with our nurses and we have them look at them and then we sign off on them too. So when you're replacing pumps, do you always restart it at the same dose or do you decrease the dose?
I've mentioned before, probably one of the most frustrating things for me is I don't always do things the same way. So, I always say there's a method to the madness, and that's a good point you bring up. If there's a kink, how do you know how much medication patients receive?
Because they could be receiving some, you just don't know.
Exactly. So I kind of go on a few different things. One is a hunch.
Sure. I mean, how they're doing.
Well, actually, how are they doing? Exactly. Clinically. Is their spasticity well controlled? Has it been getting worse? Is their pain getting worse?
Yeah.
Was there, sometimes we revise these pumps where there's been no flow coming out of the side port when we aspirate. And then patients had terrible pain control, but also withdrawal symptoms. And then, likelihood of patient receiving much is low. And then I try to tend to cut down to even 25% of the original dose.
Yeah.
If I feel that there was a catheter that's completely occluded,
Yeah.
and I replace it and put a brand new catheter in, I will often treat that as a brand new pump.
Right. Have them admitted overnight.
My practice is always to have them admitted overnight
Yeah.
if I change the dose or revise the catheter.
So how do you counsel patients about infections or pump malfunction or withdrawal syndromes?
So I always tell patients that having an implant does put you at a higher risk for infection, and to have a low threshold to contact me if they develop fever, chills, or redness at the sites. Sometimes you can develop, patients can develop delayed infections, especially in patients who have weaker immune systems. So it's important to have them very vigilant about that incision. I don't allow patients to shower for the first week to 10 days after the surgery until I look at that incision.
Yeah.
And definitely no submerging for 6 weeks. I always tell patients I want that scab to be off completely and the incision completely sealed. So in terms of baclofen, it's very specific.
Yeah.
Itchiness or pruritus without a rash, worsening of the spasticity or spasms, twitches, jerks.
Yeah.
And then often we see patients develop changes in their mood. So they become a bit more irritable uncharacteristically. Those are the most common signs of baclofen withdrawal. With opioid withdrawal, it tends to be more things like just not feeling good, diarrhea, nausea, feeling as if you have the flu, the chills, sweat, that kind of thing.
So just for our cancer pain patients, what do you tell them in terms of their expectations for pain relief or their quality of life changes? Do you have a way in which to gauge that, or is that all left to the trial, basically?
So with cancer patients, there tend to be many other things going on. And it's important to be cognizant of that, especially when it's, if a patient has a limited amount of time remaining in their lifespan, they may not want to be confined to the hospital for a recovery period. And I'm very open with them as to what the recovery is like after a pump. However, I do reassure patients that the quality of life they gain from having their pain better controlled ensures better quality of that remaining time.
Is there anything that patients have a misconception about when it comes to placing a pump?
Yes. So, patients are often very afraid of having an implant in their body.
You're right.
But I often liken it to having a pacemaker, for example.
Yeah.
If your heart is not beating right, then you need something to help it along.
Yeah.
And sure, it's an implant, but you forget it's there after a while. I have patients that horse ride, do marathons, scuba dive, and go on with their lives normally despite having a pump in place.
Does that usually kind of allay their fears, you think? Because, for instance, I've had family members that thought this pump was actually going to be external. And having that conversation about how it's implanted, but typically we can place it in a way, depending on someone's sort of body habitus, that it's not too visible, I should say. So is there anything else that helps you feel like kind of make someone feel more comfortable with approaching this?
I think in a patient who's hesitant to have a device implanted, it's important to have them undergo a trial period.
Yeah.
That's really what convinces a patient as to the efficacy of this device.
Right.
Otherwise, to them, it may feel like a shot in the dark when they've tried so many other things that haven't worked.
Because this is, we wouldn't call it a salvage therapy, but it is more of like the end of the line sort of therapy, would you say?
Traditionally, it's been viewed as that, the end of the line therapy.
Yeah.
But I feel that we really should look at introducing it earlier, especially in those patients that we know just won't do well with other interventional therapies we have. After time, you develop a feel for this. And I think introducing it at an earlier point in a patient's life will allow them to maybe work a bit longer, be a bit more productive in life, have a better quality of life, rather than waiting until they've been bedbound or unable to do much.
When it comes to how often someone needs to refill this pump, what do you tell them and what do you see and what sort of expectations do you set?
So I tell them that it all depends on the dose that they end up at, so the dose that's effective for their pain or spasticity, and that can vary from patient to patient. Ideally, we aim for a refill interval of 2 to 3 months, which isn't a huge burden for patients. Having to come in every month is a big burden for patients. So if we do anticipate somebody needing a higher dose off the bat, we put in a larger pump, or we can adjust the concentration of the medications to make their refill interval more reasonable.
And when we talk about larger pumps as of right now from Medtronic, and primarily it seems as though Medtronic is the main supplier of intrathecal therapy, they either come in a 20 cc or a 40 cc. Do you wish that were different? Do you wish there was a 30, a 35? Do you wish there were a 60? Or do you wish there was a 10? Is there any, do you have any thoughts to the sizes of pumps?
You know, I always tell patients that the 20 ml pump is the size we put in kids. So our pediatric patients get a 20 ml pump.
That's a good way.
And, you know, they get used to it. Sometimes with cancer pumps, with very high doses, they do need refills a lot more frequently. It would be nice to have a larger pump to be able to do that. However, the downside of that is that as patients become more frail, their body habitus may not accommodate a larger pump.
Yeah.
So at the moment with what we have, you know, we have to balance different needs.
Yeah. What about the maintenance schedule? How often do these pumps actually need to be replaced?
Yeah, so that usually is between 5 to 7 years. And we try to replace them or start the process at least 6 months before that pump's due to be changed.
Yeah.
Every time a pump is interrogated, we get a printout of their telemetry. And on that is the ERI, the elective replacement indicator date. And that gives you an idea as to when the pump should be replaced.
Do you tell people that have really delayed refill dates that they need to get their medication changed out or refilled at a certain time regardless of it? You know, maybe the refill date's 6 months from now. Is there any time frame for medication or?
6 months is usually the time frame, because the stability of these medications just hasn't been studied beyond that point.
Okay.
So they may possibly last longer, but we just don't have the data to support that. So 6 months is the maximum we go in between.
I think that you've done a good job of kind of saying how intrathecal therapy or ITP, so intrathecal pumps, fit into a multimodal pain regimen, but how do you fit that in your mind? Do you still continue the oral medications? Do you still think injection therapy or maybe surgical opinions is still important when someone has a pump on?
So really, intrathecal therapy is targeted drug delivery. And I try to make that clear to my patients. We're targeting a specific area. So if we're treating your low back and leg pain, the catheter is placed at a position to treat that pain. If you develop neck pain, it's not going to help the neck pain. If you develop shoulder pain, it's not going to help the shoulder pain. So a multimodal approach is very important, bearing in mind to continue treating pain at other locations with other interventions.
And lastly, just to wrap things up, because I want to be very mindful of your time, and I really appreciate your time, what do you see in the future for targeted drug delivery or intrathecal therapy? Is there anything that you think is new and on the horizon or anything you wish to see in the future?
Absolutely. I'd love to see expanded access to these therapies. In my mind, especially with cancer patients, nobody should die in pain. And this is such an effective therapy for refractory cancer pain. Also, look at, spasticity patients and chronic pain patients, quality of life. This is what we do in pain, is pain management and try to improve quality of life. So I would really like to see expanded access to this therapy.
Well, thank you for bringing it to so many people. I'm going to miss you a lot. This is, I'm wrapping up fellowship. So, but thank you so much for your time and being here on the podcast.
I appreciate all your dedication and hard work. And I see you as a very successful pump implanter in the future.
We'll see. Hopefully. Thanks, Dr. Ori.